Hi everyone, good morning and welcome to day 3 of the UK Health Week Digital Summer Series. It's the first of 10 event virtual series. I'm Steffi Gary and it's been my absolute pleasure to be your meeting host over the last few days. Can you believe we're at the final day already? So just as a reminder, each time you see me, I'll either be introducing or thanking a speaker or posing any questions that you might have during one of our Q&As. All of today's presentations are happening here on the main stage. Please do feel free to click on event agenda on the left-hand side and add sessions to your personal schedule. But you can also speak with fellow attendees using the chat function on the right-hand side. And importantly to us, we would love to hear from you with any questions that you might have for today's presenters. To ask questions, just click on the Q&A button at the top of the chat box as and when they pop into your head. And we will get to them at the dedicated Q&A sessions. This platform is also fantastic for networking, so do take advantage of that function either during the breaks, after the presentations have finished, or when you're not joining in on one of the presentations. So then we've got such an amazing final day lined up for you. Let's have a look at what we've got coming up this morning. Here it is. You can see here 2 amazing sessions lined up. At around midday, we'll hear from Dr. Salman Delvi with his presentation on an introduction to stem cells. How exciting. But up first, and starting very shortly, we have Soraya Walters, who's looking at healthcare through a different lens, the journey to well-being. At the end of each session, there will be a live Q&A with the speakers. So as I mentioned previously, please do submit your questions as and when they pop into your head throughout the event. Amazing, such a great lineup for day 3, so let's get started with Soraya's presentation. Soraya is the Digital Inclusion Outreach Manager at Good Things Foundation, whose vision is a world where everyone benefits from digital. She's going to be talking to us today about healthcare through a different lens. Really looking forward to this, so handing over to you, Soraya.
Hello, my name is Soraya Walters and I am the Digital Social Inclusion Outreach Manager for Good Things Foundation. And as part of my role, I work with community organisations across the UK who work with a wide range of people, supporting them to access digital services online, including health services as well. Today I will be talking about looking at healthcare through a different lens. So as you can see on this slide are some people who would typically use some of the community organisations that I have worked with. And these people come from a range of diverse cultural and professional backgrounds and may have experienced some sort of mental health challenges or have lifestyles that require them to need some form of support. The community centres that they go to, throughout the presentation, I'll be referring to them as online centres. And what that basically means is that these organisations have joined Good Things Foundation's online centres network, and they are committed to delivering digital inclusion activities within their local area. Now, these organisations might not only just offer digital learning support, but they also might offer that wraparound support, such as access to food banks, provide clothes donations, host luncheon clubs, offer health and wellbeing services, and have like a referral service for those needs that they're unable to meet. And so people come to these organisations, the online centres, for that holistic package of support, which includes digital learning. So we as an organisation, Good Things Foundation, have supported over 3 million people to date. We have a vision where everybody has the opportunity to benefit from digital. But when I reflect on some of the people that I've came across with various programs that I've been involved with, I can't help but think about the most vulnerable and the hardest to reach people. And I particularly think about a gentleman who I will refer to as Imran. And he was actually trafficked into the country, and he was separated from wife and child. And as you can imagine, was a very traumatic experience. And he found his local online centre as a place to not only connect and engage with his local community, but to also help him escape his suicidal ideation and develop friendships and just generally distract himself from his thoughts and feelings. And then I think, again, not using the correct name, but a lady called Elaine. And due to her very extreme high levels of anxiety, was only able to travel on the bus sort of a 10-minute distance drive away. And this had major impact on her housing opportunities because she did want to actually move. It limited her options in terms of employability, and it affected her family relationships, as you could imagine. And then I think about a gentleman called Ian, who in fact this is his real name, and you will be able to hear about his story if you're interested on the Salford City website, council website. And he actually became a carer for his mum at a very young age, was taken out of school and basically spent most of his adult life caring for his mother until she passed away. It wasn't until he was in his late 50s, I think, that he discovered his local online centre. And that really gave him the opportunity to develop those skills, those confidence skills, gain basic education, and all those sort of opportunities that he missed while growing up due to his caring responsibilities. So when I saw the title, looking at healthcare through a different lens, as you can imagine, it really spoke to me in terms of how we approach engaging with people that are living with present and historical challenges. So just to sort of recap on our model, as I say, we work with community organisations, and we work with community organisations from very much an engagement level. And it's basically going to those community organisations and services where we know that they've got that localized knowledge, they've got the relationships, and they know the community. And so they are usually the experts in knowing and understanding the best ways to engage individuals and communities. Now, what I should say is that anybody can become part of the online centres network. So we have GP practices have joined, we have housing associations, we have cafes, we have projects and faith centres, and that's due to the fact that they all have recognised that there is a need to support the people that access their services and to take them on that digital learning journey. So when we're talking about digital inclusion, our model believes that digital inclusion can help people to become able, equal and safe. And through digital inclusion, people are happier and healthier and better off. So some of the ways that we work to promote digital inclusion, which enables our online centres to reach those people that I have mentioned, is that we are very much a social change charity, and we have developed digital inclusion e-learning platforms which allow people to develop those foundation skills, which is really about understanding that there are people within the community who do have fear around using a device. They don't have the confidence to access services online. They wouldn't know how to operate a mouse, for example. So our learning platform, Learn My Way, as you can see on the slides, covers a range of topics such as how to use a computer, how to gain internet skills, and then we also look at online basics and online safety, and then through the confidence and the skills that the people have built, they can then go on to explore how to access online services such as how to apply for universal credit, managing your money online, and of course improving your health online as well. This online platform is completely free. Anybody can use it. It's available 24 hours of the day. It can be used independently or with the support from our online centres. And we also have another learning platform actually called Make It Click. Now, this is more focused around employability skills. So those people that, have gained the confidence through Learn My Way and have the motivation and interest to develop skills further can also access the Make It Click learning platform. We have designed and delivered many programs to ensure that our online centres are funded to deliver some of these programs which we offer. And we have done that in partnership, as you can see some of them here on the slides, which includes Leeds City Council, where we supported them with the tablet lending scheme. There's also Salford City Council, which I was a part of as the digital ambassador, rolling out their Digital U programme, which was specifically targeted at those people who prefer to use traditional means of communication when contacting Salford City Council and customer services. And we have also worked with Stockport Council, the NHS and the Lottery Fund. So when we're talking about how to engage and become more person-centred in our approach to digital healthcare and health services in general, we can't ignore the fact of digital exclusion and its impact. As you are all fully aware, the digitalisation of services has increased massively since the COVID restrictions and lockdowns, and there has been a lot of transformational service delivery, which is really pushing people towards accessing services online. But the reality is there is 9 million people who are unable to access the internet without support. And there's 7 million people who actually don't have internet connection at home. But what we do know is that 77% of people have said that using e-learning tools has helped to improve their mental health. And actually 44% of the population actually do engage in online health services. So currently, I'm working on the Better Health Outcomes programme, which is really a development of some successful work that Good Things Foundation has done with NHS England, NHS X and NHS Digital on the Widening Participation programme. And that was about identifying pathfinders which encourage people to access digital health services and develop digital health literacy within the community. And it was identifying those groups of people who may struggle ordinarily, or who come from backgrounds where they might be homeless, or they may be ESOL learners, so have limited English skills. And the widening digital participation programme was basically identifying ways that there is an easy sort of progression route from community into healthcare services and practices. So the element of building on that success, the element of the better health outcomes that I'm working on has been to do some insight gathering. So some of the recommendations that came from the Widening Participation Programme was to have a much more of a deep dive into particular communities or particular needs, to see how organisations are actually able to engage and retain learners or people that access their services. So working with a small group of online centres who work with refugees, asylum seekers and EU nationals, I've been observing how the organisations are really able to offer support which is holistic, person-centred, and also done in a culturally sensitive way that ensures that people feel welcomed and continue to access their services. But one of the interesting things I have found on working on the better health outcomes, and I should say actually one of the elements of the Better Health Outcomes programme is that it's very much about peer support. So it's we have capacity builders who are online centres who have taken on the role of ensuring a sort of community health best practice ways of working, and they are delivering workshops and offering that peer support to health hubs, and these are online centres who offer the digital health support. So just moving on to this slide, on a crude level, when we're talking about digital inclusion, we are obviously talking about devices, and we're talking about good connectivity. You know, I've had my own trouble since having to homework, as some of you may have already, you know, experienced yourselves. And when we're talking about devices, there's a wide range of devices. There's mobiles, there's laptops, there's tablets. And then we're talking about connectivity, Wi-Fi, public Wi-Fi, dongles, and having the access to both is really the starter point for any basic digital skills to be learned. And basic digital skills as well also has to be delivered within projects and online centres that have the resources to do so, and that are able to offer that safe environment and give the people the confidence and the self-esteem to be able to develop and implement those skills. And from that, we see that through devices, connectivity, and and support with the digital skills, people are able to reach their goals, whatever that may be. So it could be applying for housing, it could actually be making a self-referral to a local charity, and then of course booking appointments online, and registering for online health services are all could all be part of somebody's goals. But throughout my work and working with community organisations, thinking about the three people that I mentioned before, Imran, Elaine and Ian, and how the community organisations, the online centres, have really been able to adapt and reach these people in terms of providing a person-centred support has been very much something that I've appreciated, to know that really digital learning and being able to access online services isn't really done in isolation. So I've broken the three main components that I've seen that really allows you to look at health through a different lens and just considers different areas that really does help to improve people's outcomes, but also creates an area of focus and an environment of where learning is promoted and friendships and relationships are very much valued. So when I refer to knowledge, what I'm talking about are these online centres have strong knowledge on people's current needs, and they're aware of the issues that may be surrounding people in terms of historical past events that may have occurred that still have an impact on their day-to-day lives. They may be aware of family dynamics and family relationships that also impact on people's ability to maybe engage with services or may contribute to poor emotional and mental health. And then also in terms of knowledge, our online centres, when they're considering health and support, they understand the value of long-term partnerships, and with that they are very much keen to reach out to other organisations and come together to identify a long-term goal, which will support people who access their services and also the services of the partnership organisations. And then through their understanding of the needs of the partnership scope within their area, people's needs, whether it be social, cultural, personal needs. They also have a good awareness of the service gaps within their areas. And with that knowledge, they're able then to seek to fulfil that gap by looking to work with other organisations as partnerships. Next is skills, and when I think about the skills of the online centres and how they work in reaching people, and when we talk about being holistic and being person-centred, these are very much terms that kind of just fall off the tongue without actually considering what does it actually mean. And I think skills really does capture the elements of being person-centered. So in relation to approaches to work, it's very much about being dynamic and flexible and adaptable, and appreciating that as people we change, our circumstances change, our behaviours change, and designing services around those inevitabilities is really what ensures people to feel safe and allows people to feel that they're being taken on a journey rather than services and things being done to them. Next, I would definitely say it's about addressing people's fears and looking at barriers. That this is really fundamental to the foundations of the relationships that the online centres build with people. Because as you can imagine, if you're fearful, you need to be able to overcome that before you're able to fully benefit from any services. And this is very much done within the relationships, and the beauty of the online centres relationships is that they are voluntary, and so there is more of a relaxed, informal relationship, which allows people to actually share their concerns and their needs freely. And lastly, I would say when it comes to skills is, which is quite, it's quite a unique skill, I must say, is the ability to see the world through people's eyes. Sorry, I've put learners there because we often refer to people who access the online centres as learners, but yeah, they're just people. Yeah, being able to see through the world through people's eyes is a key skill in terms of thinking about working and promoting equality and anti-discriminatory and anti-oppressive approaches. It's about really being able to embody that empathy and value people's lived experiences, and understand how certain wider elements of people's lives may have impacted on their health conditions, whether it's exacerbated it or caused it to deteriorate, or just been the creation of because of a traumatic event. The online centres staff and volunteers really do appreciate the learners' experiences, and use that, and then use their experiences actually to go on to inform and direct the way that they work with people. And lastly, I would say the behaviours that the online centres exhibit really do sort of promote care and recovery and rehabilitation in the way that they are friendly, they are approachable, they understand the importance of providing a safe and nurturing environment. And when I reflect on some of the online centres that I've visited across the UK, with some of them, immediately as you enter the building, you can feel that community support, you can feel that peer support. It's almost that unwritten, we're in this together. As other people who may have similar needs are accessing the services. And then sometimes, in some cases, there's staff and volunteers who actually have that lived experience. And so that really does influence your behaviour and how you treat people when you are supporting them. In terms of continual relationship building, again, this is about seeing relationships as voluntary, seeing them as partnerships, really, as something that needs to be developed and nurtured, and often taken at the pace of the person. So, for example, there are many online services that have, the sessions are timed, or there's a limited space to kind of complete a certain task. With online centres, because there's the awareness of that the person's backgrounds and the person's needs, it's more about supporting the people to complete the activity or get things done correctly, but at a pace that allows people to fully understand and comprehend what is it that's being asked for them. So it's very much about seeing relationships as a journey. And also in terms of partnerships, their behaviours are very much about seeing partnerships as an opportunity to balance power and to remove any barriers, and to be proactive in seeking those partnerships, whether it be with the people that you're supporting, whether it be other local organisations or strategic funders. Having that mentality and that attitude that, every relationship is a partnership is something that I have found to be crucial to the way that our online centres have been able to engage and maintain valuable relationships on all levels. So just to kind of update you on what we're doing as Good Things Foundation to really raise the awareness of digital exclusion and promote digital inclusive practices. We published our 100% digitally included nation blueprint last year. And we have really appreciated listening to the feedback and responses from our online centres, which I should also add, we have, I think, over 5,000 community organisations, as I mentioned before, which are very varied, that are part of our network. And we've really, over the last year and a half, listened to how they've had to change and adapt, and how digital exclusion has really been put on the forefront for many organisations as they struggle to reach people who they knew were very much vulnerable in the community, but they wasn't able to contact them due to them not having any devices or the connectivity or the skills. So, and I know, and probably for yourselves also, the plight of digital exclusion has really come to the forefront, and digital inclusion and remedying that has very much become part of people's priority. So with that said, we have got 3 key policy asks from the government. We are asking for £130 million to reach 4.5 million people in 4 years, and that'll be working with online centres, businesses, corporate partners, and really just coming together to really reach people that need digital skills the most. And as you can imagine, people that are more dependent on digital are the ones that say who may be reliant on benefits and housing, council housing and social services and social welfare services, which have all become online. So it's really important that we kind of all get behind the digital inclusion strategy. And second, we have the Data Poverty Lab, and that's very much about bringing people together with lived experiences who have little or, who have no data and little access to data. And it's really about co-designing different approaches to see how we could donate data to people. So it might be through gigabit, or it might be through people donating unwanted data. There's loads of different sort of ways that we could kind of look at the best way of ensuring people that need data need it the most. But what we do need is that sort of co-design approach so that everybody is involved to support the Data Poverty Lab and test and research around that. And then lastly, we're calling for a digital strategy for everybody, and that's to ensure that nobody is left behind. And again, as I just said before, the strategy is really about making all organisations, businesses and sectors really embed digital inclusion, and so that they are able to reach the people that they either support or employ, and so that everybody is given the opportunity to gain the digital skills that they need. So in terms of next steps, now I appreciate that some of these steps won't be relevant to everybody. But before I kind of go on to these, one of the key asks would be, my apologies, one of the key asks would be to reflect on some of the points that I've raised today in terms of when you go back to your offices, when you're speaking to your colleagues and partners. It'd be really interesting to maybe start having those discussions about those people who you don't reach, those people who your services are not intended for, and really maybe try and explore building partnerships with people that actually do work with those groups or communities of people, as a way to enhance the work that you're already doing and to widen the audience. And what you may find is that that there's organisations out there who will be able to complement the work that you're already doing, or if not, just help you to inform some of the decisions that you may make, and so that you are actually starting to really think about shaping your delivery, making it more person-centred and holistic, and reaching those who are often labelled hardest to reach. So just going back onto next steps, I would recommend that you visit our Good Things Foundation website, where you can have access to our blueprint and numerous reports that we've done in the past, and there's also resources available. Again, may not be relevant to yourselves, but you could also take a look at Learn My Way, the free e-learning platform that I spoke about earlier, and as I said, it is designed to support people with little or no digital skills. It may be something that you may want to share with other organisations that you're currently working with. Thirdly, again, if you were aware of any organisations or you are interested yourself, please do feel free to join the Online Centres network. It's a completely free membership, and it really is there to support organisations to really roll out digital inclusion activities within their area. So you will find access to training, webinars, there's a funding database as well, and there's also session plans to support face-to-face delivery and or even remote delivery, as the case may be now. And then fourthly, I would recommend, again, either yourselves or suggest organisations to get involved in Get Online Week, which is our flagship campaign. It's all about promoting digital inclusion, and it's an opportunity for the members of our network to really promote digital inclusion and what they're doing within their area, raising awareness. We often provide the resources and sort of promotional material to make it, you know, more of an event. And this usually takes place around October. And yeah, it's about celebrating digital inclusion, shall I say. So that's the end of my presentation. On the next slide, you can see my contact details. Please feel free to get in contact, and I will look forward to any questions that may come up. Thank you.
Amazing. Thank you, Surya. Amazing presentation there. And it's nice to see you. How are you doing?
Not too bad, thank you. How are you?
Fantastic. Yeah, good. Thank you. So if anyone's got any more questions for Surya, please do send them in. I do have a few already that have come in for you, though, Surya. So let's start with this one, which is, how has COVID exacerbated the plight of digital exclusions?
Thank you for that, Steph. Well, in terms of COVID, I mean, the reality is that digital exclusion has always been present. It's just that really when the initial lockdowns occurred, it was that great realization with businesses, just everybody really, schools was, you know, were unable to contact some of the most vulnerable people that we have within our communities. And that really kind of brought digital exclusion onto the forefront. As you were probably aware, when everyone was sort of in emergency mode, it was like, how do we get medication to people within the community who may be housebound? How do we, you know, maintain that communication with people who we know may be experiencing like mental health problems? Food parcels for the elderly, or people who, you know, have difficulties with mobilisation. So it really has become, digital exclusion has really become part of people's agenda now, because it's about engagement, and it's also about how you support that person as well to have the skills actually to continue accessing whichever support that you are offering. you know, when it came to young people, for instance, you know, there's that assumption that young people are sort of digital natives and all young people have a digital device and all young people know how to use them. But, you know, the government was quite surprised by the level of digital exclusion amongst young people. So it's really been heightened on various levels, really. And when we're talking about digital exclusion, you know, nobody is, you know, everybody's kind of in the same boat. You know, some people are more at risk of digital exclusion than others, but essentially it boils down to having access, the skills and motivation, for sure.
Absolutely. Sorry, I can feel something in my throat. I'm trying not to cough mid-sentence. Thank you so much. And actually really interesting that I heard you say, you know, in your presentation that 9 million people in the UK need support accessing the internet and 7 million people don't have the internet at home, which is a much bigger number than I imagined, just like over 10% of the population. So how do you think that the majority of these people access the internet when they need to, if they ever do? I'm sure, I mean, I've got a 98-year-old grandma, she doesn't need the internet, but, you know, when people do, and, you know, how can they be further supported either by Good Things Foundation or local councils or any other organisations?
Yeah, thank you. I think that, you know, for, you know, taking your grandma as an example, you know, should she need to access an online service, you know, she might come to you first. And so family and friends are a really good, strong, you know, network of support. However, those people that don't have that option and who are isolated, engaging in your local community centres, and I don't know whether they may have key workers would be ideal, but of course, engaging with our online centres, Good Things online centres. And as I said, these are community organisations that are dedicated to supporting people develop their digital skills right on a basic level. And yeah, so they can either get in contact with Good Things Foundation, see what local online centre is within their area, and maybe also contact they can also contact their local trust or council, because as I said previously, because digital exclusion now is becoming so high on people's agenda, there is a lot more support that, you know, there had been previously to COVID, which is some of the benefits, I must say, that have come out of COVID, if I dare say that at all.
No, absolutely. I mean, there's been a lot of people mentioning this, you know, it's not been a positive thing, but there are positives that have come out of the pandemic, and I do think this is hopefully one of them. So that's good. Okay, so we've only got a couple of minutes left. Would you like to end by telling us what are the benefits of becoming a member of the Good Things Foundation?
Yeah, for those organisations that are considering joining our network, but maybe reluctant, because I do come across people who are a bit like, oh, I'm not too sure whether to take that big step. When you become a member of our network, you really can take it as you please. I mean, there's a lot of services available. There's training, and we hold regular webinars. As I said, there's resources, and just being able to pick up the phone and have those initial discussions of, you know, I've got many people in my area that are digitally excluded. We have no access to devices. You know, there's a specialist on the other end of the phone there, and who is friendly, and is able just to have those conversations, those reassurances, maybe even connect you with a local organisation in your area, and you can do some shared learning. Yeah, so there's a range of support there available. Or we might just want to benefit of some of the resources as well. There's session plans if you want to really get going with remote support or some sort of delivery. But yeah, please, the first step is just take a look. It's absolutely free and it's available to anybody.
Amazing. Thank you so much. It's been really wonderful having you, Surya, and we'll see you next time.
Okay, thank you. Take care, everybody.
Thanks. Bye. All right, then next up, we'll be hearing from Dr. Salman Dalvi, the Chief Executive at Global Regenerative Medicine Society. Salman will be giving us an introduction to stem cells. So don't forget, you can submit any questions for Salman via the Q&A button in the chat. Such an interesting topic. Can't wait to hear more. So handing over to you now.
Thank you, Stephanie, for introducing me. That's really kind of you. I'll just quickly take a few moments to speak about myself. I am Salman Dalvi. I am currently the Chief Executive of the Global Regenerative Medicine Society. We are here to talk about and advocate stem cells and regenerative medicine. I've been in this field for roughly 15 years, and I started my career at the NHS Blood and Transplant and collecting cord blood stem cells and using them for transplant into sickle cell anemia, leukemia, thalassemia. These are all diseases that were initially to do with stem cells. And you may have heard of People may have heard of bone marrow transplants, need of donors for bone marrow transplants. So I started my career there at NHSBT, and we worked at the Anthony Nolan in conjunction with Anthony Nolan to develop centres in the UK for about 6 collection sites of cord blood stem cell transplants. I then moved on from there and was very fortunate to be able to be one of the pioneer of having what you call a hybrid model of stem cells collections, and that meant there was a partnership between the NHS and a private cord blood bank to collect stem cells which are derived from cord blood or placenta, and we were happy to have a very, very good partnership developed in the UK. 6 hospitals, north and south of both involved. People now talk about Manchester and Bolton being known for COVID, but we actually started with a very good transplants collection of stem cells at the Bolton NHS Foundation Trust. That was very, very good. I then went to become internationally and served my time as a director of the World Cord Blood Association, which was also there to promote and advocate stem cells. And today I'm here speaking to yourselves about an introduction to stem cells and regenerative medicine. So without wasting your time, I'm actually going to go on to the next slide. As you can see, if you have any questions, we'll be able to take them at the end, and Stephanie will be able to help me with that, I presume. So what are stem cells? Stem cells are the body's building blocks. They are the raw materials that every other cell needs for their own function. They're specialized cells that are formed initially in the embryo as we start our journey into and get born. These cells are unique, and they have what the unique functions, and they can be characterized and because they can be characterized and divided into any other cells, which are called daughter cells in the lab or within the body, and they can be used for regenerative medicine or to regenerate cells of any particular kind. Why is there such an interest in stem cells? Why is everyone talking about stem cells? You hear on the news about stem cells. You look at in the paper. You're looking at the papers. People are talking about stem cells, stem cell donations. It can be very confusing. So let me explain a little bit as to what the researchers and doctors believe stem cells can help us. It's increasing the understanding of how diseases occur. By watching stem cells mature into cells in the bone, the heart, the nerves, and other organs and tissues, the eyes, researchers and doctors believe that there may be a better understanding as to how diseases and conditions develop. Secondly, generally healthy cells are needed to replace diseased cells. That's where we talk about regeneration of medicine. We believe as scientists and as doctors that stem cells, which have the capacity to regenerate tissue, stem cells can be guided into becoming specific cells that can be used to regenerate and repair diseased or damaged tissue. For example, stem cells currently are being used for leukemia and many other cancers. Okay. There are also stem cells studies ongoing that will be looking at autism, which is an interesting study. So before I even go further into this, let me just make people understand, uh, or you may know this already, so it's not making you understand, but just highlighting the point that the stem cells can be derived or were initially derived from bone marrow, and they were collected in medicine from bone marrow, and they were used as what you call as bone marrow transplants. Then in about mid-80s, we started collecting stem cells from cord blood, and they are called hematopoietic stem cells and cord blood stem cells, and those were used for transplants as well. So the best sources of stem cells normally are either from the bone marrow or from cord blood, and they can both be used for transplants. So going back to that, people who might benefit from stem cells, therapies include people who have got spinal cord injuries. You may have seen that on the telly. There have been cases that have been shown. People with type 1 diabetes, there's a lot of research ongoing with type 1 diabetes. Parkinson patients, Alzheimer's patients, heart disease, stroke, burns. Burns is a very important area, especially in 2015, 2017, when we had the Middle Eastern crisis with Iraq. There was a lot of burn victims and shrapnel wound soldiers who came to the UK, and they were treated with stem cells that were derived from the placenta or the amnion part of the placenta. Many cancers and osteoarthritis can also be is also an area that will be looked at and can be where stem cells can be used. Stem cells may have the potential to grow or become new tissues in transplant and regenerative medicine. Our researchers continue to advance every day on stem cells and their applications in regenerative medicine. This means that we're looking at over 7,000 rare diseases currently that have no cure. Maybe stem cells will be able to help them. Again, I'm going back to the same slides. I think I've gone a bit forward. As in stem cells, what are they currently used to treat? So currently, doctors perform stem cell transplant from the bone marrow, and they are used to replace the damaged cells, and they would be used for diseases like leukemia, lymphoma, neuroblastoma, and multiple myelomas. And these stem cells would be used from cord blood, or they would be used from a bone marrow transplant. Cord blood is something that I really would like to see develop more into therapies, into daily use, because cord blood, it's an off-the-shelf product whereby when you use a bone marrow transplant, you have to have a registry which is huge. You have to go and take cheek swabs, get donors to come and queue up and then find a match to get a right match, because you need to find the right tissue type to be able to match stem cells and to be able for them to be transplanted. So that can be a cumbersome process. Cord blood, on the other hand, is a lovely, it's a lovely off-the-shelf product. So baby is born, and it's a very safe product. If you initially get the mother to consent in the hospital when she's about 30 weeks onwards, and she knows that she's going to, you then ask the mother to, when the baby is born and the placenta is expelled, and the mother is safe, the baby is safe, a collection team would go and collect the placenta, and they have about 8 to 9 minutes before in which they can collect up to about 100 mils of cord blood, of the blood that remains in the placenta. That placental blood can then be used to transplant into a child who may have sickle cell or thalassemia or leukemia or other bone marrow diseases that are there. That's a nice off-the-shelf product as long as you get it tissue typed and it just stays at minus 80 degrees in a controlled rate freezer. And whenever there is a match, you take it off and you can give it to someone. There are people in the United Kingdom. There are stem cell companies or cord blood banks, which are called, that also help to people to store their own stem cells. However, storing your own cell for yourself and using it, the cord blood in future, is still a long way off, and we don't know many occasions where cord blood is being used for that particular reason. One of them is to do with the costs. Our organization is actually trying to make sure that there is accessibility to stem cells, and also there is a affordability. It should not be the domain of the rich to be able to use stem cells. Everyone, whether you are a patient from a third world country or a patient in the United States or first world country, providing you need stem cell transplant and providing there is proof that this transplant has happened, the collection has been ethical and it is proved and it's regulated, the therapy has been regulated, then you should be allowed to get the transplant. There may be a case over here for a warranty of some kind, which should be able to pay for regulated stem cells. We also work with new investigational drugs. So basically, any stem cell therapy, it can't be, oh, I want to regenerate my eyes, so I'll collect some stem cells and go to an X country where it'll be transplanted. It is not that easy. It has got to be regulated, because on the pitfalls of not having a regulatory therapy could mean that you could lose an organ, or if it was the eyes, you could lose a sight. Rather than gaining sight, you would be losing your sight. And that could be, well, we know the consequences of not having sight. So it's important that the diseases that we are treated should be regulated, and we should be able to talk about regulated treatments paid for in the UK by the NHS or by private healthcare through a warranty scheme of some kind. Are stem cells the future? Is regenerative medicine the future of medicine? There are over 900 clinical trials that I know, which are coming to a stage where they may be regulated within the next 5 years. As I said earlier, the one that I think of, which is very important, is diabetic wound ulcers. Stem cells from the placenta. So imagine this, okay? Baby is born. Placenta normally go in the bin. Instead of the placenta going into the bin, you take the placenta, take it into a lab, into a clean room, clean it up, wash it, take this, separate it and cut it into squares, and take the squares and bandage the squares onto a person who's got a diabetic ulcer and whose leg may need to be amputated. And you use that little piece of tissue, and in 3 weeks or 5 weeks, you see an engraftment, and the wound starts healing, and there's no need for amputation. That saves a lot of money in the NHS from one piece of tissue that would be thrown away normally. There's millions and millions of liters of cord blood which are normally thrown away. If they were donated and they were used properly, we would be able to save hundreds and thousands of lives and regenerate hundreds and thousands of organs. Whether it is through the NHS or private healthcare, it really does not have a difference, providing it is affordable and we can use it to help people. I'll be able to take more questions on this, and Stephanie will be able to take more questions at the end of this session. If you have any questions, please do let me know, and we'll speak then. Thank you for your time. It's been a short presentation, and I hope you've liked it.
Amazing. Thank you so much, Salman, who is here. We can see a picture of him here and we can hear him live. Are you there, Salman?
Yes, thank you, Stephanie. Thank you. I'm here.
Fantastic.
Any questions?
Brilliant. Brilliant to have you here. Really enjoyed that presentation. It's very interesting. I must admit I knew very little to none before, and now I feel like I'm much more clued up. Thank you. So we've had a few questions come in for you. If anybody does have any more come in as we're chatting, please do submit them via the Q&A button. But the first question is, Salman, you say stem cell research can revolutionise the practice of medicine, but how realistic is that? And how do we get closer to reaching that goal?
Okay, a very interesting question. Realistic. So the first stem cell transplant was in the 80s, and stem cell transplants are currently done in the NHS or abroad for cancer treatments, very easily done for cancer treatments. For regenerative medicine, it is a new field, and that field will be getting accessibility and affordability is currently prohibitive. Okay, so in the UK, the NHS has got its own clinical trials whereby it may use certain therapies, maybe regulated, maybe Parkinson's. There's a couple of going on. And globally, in the United States, as I said, there may be about 900 different clinical trials from autism, which is everyone talks about autism these days, through Alzheimer's patients. So or even from for dermatological problems, there are a lot of trials going on. The trials are good to the extent that the efficacy and the safety, the efficacy and safety trials, and it's not too much in the distance that organizations like the FDA and the MHRA and NICE would be able to regulate them and get them out as therapies. Currently, there are 80 different diseases that are cured, but as I said, there are 70,000 rare diseases or genetic diseases for which we don't have a cure, and providing funding was available, we would be able to get something out for everyone.
Absolutely. Wow, that's quite a large number. That's thrown me a bit. So yeah, speaking of affordability, then somebody has asked, how affordable are stem cell therapies? Is it, currently for the super wealthy, or are we soon going to be in a place where it's going to be accessible to everybody?
Our global society is trying to make it affordable and accessible. That's our primary objective, and that's my primary objective, is to make sure that it's affordable, it's regulated, and it really does work. There are stem cell clinics that are popping around the world, and everyone says, "Oh, I can go and get a stem cell treatment for Alzheimer's or Parkinson's and pay £2,000 or £3,000, and I can have an injection." But that's short-lived. Okay, that's not regulated. When it comes down to regulated treatments, currently something that is regulated or something that is would be it's not affordable. We're looking at the other day, there was on the news, they were showing that there was a approved gene therapy or approved stem cell therapy a product that was used for a particular child, and it was costing £200,000. So it's not affordable. Yeah, the NHS unfortunately currently is not funded for many of these treatments, and where it is, it's a postcode lottery.
Yeah.
So it may be a good idea to have for people who are considering to join maybe a warranty scheme whereby if you are fit and healthy now and you know the future of medicine is coming, you might as well have a warranty, join a warranty scheme, pay a subscription over a period of time, and get affordable treatment. That is something that we'll have to look at in the UK.
Okay, that's really interesting. Amazing, thank you. So we've got a couple more questions then. Next one is, how can we provide more guidance for countries around the world on stem cells and regenerative medicine? What are your thoughts on that?
Yeah, this is an interesting question. We have the World Bone Marrow Registry. We have the ISCT, which is there to regulate stem cells. Stem cells are regulated, but advocacy and the group that we have formed is patient-centric. So patients should be able to. You get a little bit in the UK when you've got Macmillan may do some work, Anthony Nolan, who are brilliant champions of cord blood and stem cell bone marrow transplant. Amazing organization, amazing charity. Who they are doing a lot, but when it comes down to patient-centric and globally, it depends on the country and the regulations of the country. It is political, and with G7 happening now, maybe someone, one of these health should be discussed as well. Everything is centric around COVID currently. Maybe stem cells should also be there because there may be a treatment. Stem cells may be able to be used in the treatment of COVID. It is being studied currently with the FDA.
Interesting. Yeah, I wonder if it'll come up. Brilliant. So we've got one more question for you then. Do you think there is need for a global advisory committee to be formed on regenerative medicine?
A global advisory committee. This is an interesting question once again. An advisory of what? And who will sit on that committee? Okay. We have the APPG, and people sit on the APPG. We have the Congress, which is lobbied in the States. Really, what is an advisory committee, and why would you want a group of advisors because it's such a medicine is such a regenerative medicine is because we degenerate as humans. So every specialty may have their own professors. So if an ophthalmologist and a group of ophthalmologists are talking about regeneration in their area, there's no way someone from orthopedics will come out and say, can talk about that, or they may want to because of regeneration, but that's not really the right way. Yes, a consensus can be formed that a consensus group that stem cells are the future, and that's why we have the Alliance for Stem Cell Therapy, and then we have the Global Regenerative Medicine Society, we have the Cord Blood Association, we have groups that already exist, and they are groups based on clinicians who know the clinical aspect of it. And then the idea is to get a medium whereby clinicians who specialize and who have done transplants, say maybe in India or at Duke in America or at Oxford over here, should be able to share their knowledge and allow their knowledge to be transmitted to the common person on the street. It's not always easy for a person who goes into a hospital to know, okay, my diabetic, I can have a stem cell transplant as well for leukemia, or I can also look at that, or someone wanting to donate stem cells. It's difficult. And we tried between 20 countries to harmonize the regulations, and it took us about 9 months to harmonize regulations across the globe. So it's been done. You need like-minded people. And you need people who want to be up at 2:00 in the morning and 3:00 in the morning because of time gaps to be able to get consensus. But it would be a good idea to have some sort of a forum.
Yeah, definitely. Really interesting. We've only got about a minute left. I feel like I could talk about this with you for the rest of the afternoon. It's so interesting. But do you have any final comments or words you would like to say on the matter, or where can people go if they want to speak to you or find out any more?
If they want to speak to me, it's clear you can get in touch with me on via yourselves or at salmanconsultants@gmail.com. I'm quite happy to speak to people. I'm happy to answer questions. And as we go forward, we will be able to discuss things. And I'm happy to come on forums and help speak more about the product, about the subject. I can go into specifics with different topics, but yeah, limited for time.
Yeah, absolutely. I bet there's so many different, avenues to go down and loads of specifics. So this is a very brilliant overview, introduction, as you might say, to stem cells. So thank you so much for joining us, and we will hopefully see you as well as hear you next time.
Thank you. I'm
Thank
sorry
you so
about
much.
this
No,
technical
it's fine. Absolutely fine. Thank you so much. Brilliant. What an amazing morning. Thank you so much to all of our speakers and to all of you for your input so far. It's now time for a short break. And as I've said the last couple of days, we do encourage you to take this time to stand up and move away from your screen. We're looking at them all day, every day. So let's have a bit of a break, and we will see you back here in about an hour. See you then, guys. Hi everybody, welcome back. I hope you're suitably refreshed and had a lovely break. We're now into the final section of the UK Health Week Digital Summer Series, and we have some really brilliant sessions lined up for you to end today's event. We're shortly going to hear from Professor Rotimi, who will be presenting on health tech, keeping up the momentum. To close the day, we also have Liz Ashall-Payne, who will be talking to us about collaboration and trends in health tech. So don't forget, at the end of each session, there will be a live Q&A with the speakers. So please do submit your questions as and when they pop into your head throughout the event. All right, then first up, then let's welcome Professor Rotimi, who is, among many other things, Associate Medical Director for Patient Safety at Mid and South Essex Hospitals NHS Foundation Trust. He's going to talk to us about health tech and how we can keep up the momentum. So, Professor Rotimi, the floor is yours.
Thank you to the organizers of UK Health Week for inviting me to come and share my knowledge with attendees. I am Rotimi Jayasimi, Associate Medical Director for Patient Safety at Mid and South Essex Hospital in Essex. I'm also a consultant in obstetrics and gynecology and an NHS patient safety specialist. I also practice law as an ordained professor of law at the University of Ibadan in Nigeria. And I'm also the CEO of Trojan Medical Group, a medical infrastructure group. So thank you for the kind invitation. And good evening, good afternoon, and good morning, wherever you are in the world. The outline, there are no conflicts of interest to declare. What I share with you today are my personal views and not any of my employers. Neither am I being paid by any organization. The outline of my talk, which is keeping up the momentum post-COVID, is what you've seen on the screen. We will be talking about the adoption of digital health technologies, remote consultations, electronic prescribing, artificial intelligence, and big data in the use of tracking during the pandemic, embedding these existing and new technologies for the long term, and then reflecting on COVID-19 pandemic to inform the health system as we go into the future. We all know that in December 2019, when the outbreak of the pandemic started, digital health wasn't very embedded in healthcare practice, more so in the United Kingdom. But it was a tool that we had been looking at. And in the NHS long-term plan, we had consideration for the use of emerging digital technologies. But it wasn't commonplace in the NHS. There was apprehension and resistance to its use in certain sectors of our services. The NHS guidance and limited academic research on remote consultation urged caution. We were advised to take it slow, bring colleagues on board, be flexible to ensure no one is left out. But like I said, December came in, and into January, we never expected the pandemic. And this overturned the slow adoption process that we had towards digital health. The pandemic opened up a new space, a portal to rethink everything. How we live, how we work, how we produce scientific knowledge. You didn't have to go through peer reviews to put in new knowledge out there. How we provided healthcare, how we related to each other in society, and how we related to non-human animals in the planetary ecosystem. Now, to achieve social distancing, which was one of the non-pharmaceutical interventions that was put in place, it was important that in healthcare, there was the no touch. You didn't want to go too close to people who had the infection. And the existing digital tools that we had then included Internet of Things, artificial intelligence, and biosensors. And these were deployed during the pandemic and are still being used as we speak. So the pandemic switched the use abruptly and exponentially because we went into remote medicine, remote consultation, telemedicine. So digital technology is now used for diagnosis. It's used for surveillance of the disease itself and in prevention of the disease. When we talk about remote consultation, the artificial intelligence digital solutions was used in diagnosis. Now, for example, it was used in making a diagnosis of COVID by using the tool to look at X-ray pictures or CT imaging, where you could see the typical ground glass appearance in COVID patients. And this was a useful tool in knowing non-COVID pneumonia from COVID pneumonia. That was very helpful. Now, online consultations was now, or is even now the norm. People could sit in the comfort of their home and speak to their GP or family doctor, or to even doctors within the hospital setting. It made it possible again to reach people who were vulnerable, who couldn't come to the hospital easily, or people who lived far away and perhaps had to take a number of buses to get to the hospital. So using remote consultation with the various systems available for non-commercial or for non-commercial reasons, I wouldn't mention the different types that are available, but there are many that are bound where you can have a video consultation or just an ordinary audio consultation with your patients. So telemedicine, for example, people would say, then how are you going to measure my blood pressure? Or how are you going to measure my heart rate? But the smartphone we all carry around has got a lot of gadgets or accessories. The flashlight, the camera can be used for looking at skin condition, the microphone, microprocessors that are within this system can be used and were used for measuring oxygen saturation, blood pressure, heart rate, breathing rate, temperature, and again deployed to use for pulmonary auscultation. These parameters were used to evaluate suspected patients, perhaps patients who were in homes or patients in very remote areas. And when you collected the data was transmitted to call centers or to what you could call a central command, where you had qualified professionals who could interpret the information that was being relayed. So patients did not have to come to see us physically. Now, this was necessary because, as we all know, and I'm sure as you've heard during this conference, that COVID itself requires human-to-human transmission. And it was for that reason people were advised to stay away from hospitals and to stay away from the general practitioners. Big data was also used in tracking the pandemic. For example, in an effort to stop the spread of the virus, a number of European countries collected information on the movement of residents using cell phone data. This helped determine who stayed at home during the restrictions and those who were not abiding. And more recently, with the easing of the lockdown, digital technology is being used to monitor where people have been, whether it's a restaurant, whether it's a bar, or whether it's a sporting venue, such that in case somebody is known to have contacted COVID, it will be easy to do contact tracing of people who were in the environment. We know that Facebook and Google wanted to use their data for monitoring, but this was considered a breach of privacy and it was not allowed. I'm sure the discussions about that are still ongoing. Now, in this picture shows you the tracking apps. Depending on what type of phone you use, once you go into the store, you can download different apps. The National Health Service has its own tracking app, and there are various ones. And again, these are very useful in telling us where you've been. We also have apps now that tell us whether you've had your vaccine, whether it's the first dose or it's the second dose. And again, you also have on your phone apps that are used for consultation. Talking about electronic prescribing, it's a digital tool that's coming into practice within the National Health Service. But there are still a number of hospitals or trusts that do not have electronic prescribing. But what the pandemic showed was it just increased the amount of e-prescribing, such that now 85% of primary care prescriptions in England are done electronically. Previously, you had to go into the GP practice to collect your prescription, go to the pharmacy to collect your medication. But all that has changed as a result of the pandemic. Prescriptions are sent electronically or even at times by email. And it has its own benefits, increases efficiency, it saved the NHS money, and it helps patients and staff practice social distancing by reducing that physical contact. In addition to that, the benefits of electronic prescribing includes patient safety. The degree of making errors through manual prescription or handwriting has been eliminated by electronic prescribing. And we also know that this has an effect on the reduction of antimicrobial resistance, as well as identifying interoperability between platforms. Now, I have spoken about accurate diagnosis, specifically when you look at lung disease on CT imaging. But we've also known that when you have accurate diagnosis, it affects clinical coding. That is one area of healthcare that we still struggle with. But with accurate diagnosis, the primary and second diagnosis, we will get better coding, and trust gets remunerated for the services they render. And the beauty of this is that these are collected in real time. So the data is real-time data. Yes, artificial intelligence. We are a little bit apprehensive about this. We say, oh, are machines going to replace human beings? What's going to happen to us when we now adopt artificial intelligence? Human beings are not going to be replaced. You still need the human interface in all of these. So the exceptional things artificial intelligence can do, they include the capacity to make our processes better, smarter, faster than ever before. Then the mundane task or repetitive task that is undertaken by human beings can be replaced by artificial intelligence. And it also has impact in life-altering decisions. During the pandemic, which we're still experiencing, we've seen the use of artificial intelligence as an evidence-based medical tool that has helped a lot in fighting this infection. Population screening, suggestions about the infection control, medical notification of where you have high prevalence of the infection, and again, improving the planning, treatment, mode, and reported outcomes, as well as modeling, predicting what could happen if you put in a number of factors together. Artificial intelligence has been very beneficial in doing this. It's also used for high-risk patients, identifying high-risk patients. This is using algorithms. You feed it into a system, the different parameters of the individual, perhaps pre-existing comorbidities, their background medical history. You put that into a system, and it gives you a score of whether this is a low risk, medium risk, or high risk patient. And again, it's useful in controlling the disease progressively. It can anticipate a mortality hazard by adequately analyzing the previous data of patients. Talking about big data, and for example, you're talking of more than 450,000 chest CT scans being interpreted by artificial intelligence. You can imagine how many man hours it's going to take to interpret this. But what artificial intelligence has done is to provide us with the ability to provide results real time and as quickly as possible. Now, in the use of tracking the infection or the pandemic itself, China, for example, used geographical information system and satellite imagery along with location tracking, robotics, and drones to contain the virus. So big data could be key to tracking COVID-19 as well as in easing the lockdown. And there's no doubt that we have also been using this in the United Kingdom. We know where the high prevalence rate is, more so with the new variants, the Delta variants, the Alpha variants that are now within our borders. So using this help us to track the disease. Artificial intelligence, I have spoken about that, and I have spoken about machine learning, but they can make sense of mountains of data from a few experiments by finding patterns that a human mind may fail to spot. One of the issues we had with vaccines, while there was some resistance in certain sectors, where people questioned the rapidity in which we were able to develop or find a vaccine. Finding the vaccine, the development of the vaccine had to do with using big data, using technology to interpret the trial results. Now, when building a manufacturing process, for example, you needed storage centers for certain of the vaccines. One of the things that big data held, as well as in artificial intelligence, was you didn't need to wait for the vaccine to be ready before you were able to plan what you were going to build, what it was going to look like. So artificial intelligence can create an intelligent platform for automatic monitoring and prediction of the spread of disease. Manufacturers can see how the production cycle can affect the quality of the vaccine and discover approaches to optimize its use. So these are the benefits that even manufacturers who are not clinicians employed or deployed during this pandemic. Now, mobilizing artificial intelligence and big data, I have spoken about the ability to predict using information that is fed into different systems. And artificial intelligence has that ability of giving everyday updates of patients and furthermore providing solutions. At the onset of the pandemic, we were not too certain as to how to manage this condition. But by collaboration between various countries in the world, non-governmental organizations, using big data and using our trial results, we've been able to show which interventions are very effective. Do you use ECMO? Do you use CPAP? Do you use the ventilator? All of this were fed into systems, and now we're better at managing these patients who have COVID. I've spoken about the different technologies. I have spoken about how, yes, they were behind us in the lodge, but how we never really embraced them as an organization or as a health service. We are aware of how much we have spent in trying to create an electronic health record, albeit unsuccessfully. But COVID-19 has changed things, and we mustn't let the gains we've made from the pandemic to disappear when we have things under control. So we have to embed these existing and new technologies for the long term. Whatever system that is built must allow for efficient interactions and the delivery of near real-time data-driven contributions to systems medicine and the ecosystem. There are issues to technology. Yes, we've spoken about the benefits, how good they are, but it's not without problems. Internet connectivity, even within the United Kingdom, is an issue. You can imagine if you're living in a high-rise building, your connectivity might be poor and it might be difficult to even undertake remote consultation. There are areas in the country where the broadband coverage is very poor. How do these people access health in circumstances such as which we find ourselves in now? And again, yes, we all have smartphones, but it's also an expense to the end user who pays for it. These are not unsurmountable problems if government invests in them in good broadband width. And I'm sure that is coming. With any new technology, there must be caution. We must exercise caution as we approach it. I know at the beginning of my talk, yes, I said people were a little bit reluctant just to embrace it. But in everything we do, we still have to exercise caution to ensure that we provide a safe care. What we have found is that emerging technology has not been a panacea for all health issues. There are burning concerns. People are worried about data. Data being stored in the cloud. We are aware of people trying to commit cyber security problems, hacking into systems, as well as the safety of information stored on these areas. So there are issues that we still have to address, and they are being addressed. As artificial intelligence systems proliferate, it's not enough just to be accurate anymore. The cutting edge must evolve beyond the hunt for pure accuracy to encompass the qualities and technologies that result in a more responsible, ethical, as well as a trustworthy system. In the high stakes and high value settings where artificial intelligence is being applied, we need systems whose behavior we can fully explain and whose outcomes in specific instances we as human beings can exercise control over. So there's a need to look at policy development. When the pandemic came, like we said, it just came upon us. A number of decisions and interventions were made as we went on, as events unfolded. affected the opportunity to address principled questions on the broader and longer term impact that digital technology will have on the democratic governance of the planetary health and society. So the uncertainties were technical, biological, spatial, political even. For example, we don't even know where the origin or what the origin of the virus is. And there are lots of things going on around. So it's important that we do not overlook enacting or putting policies in place that will help us guard science, that will help us guard human rights, as well as the everyday practices of democracy that we take for granted. People are worried that with so much data being transferred through digital tools, through our telephone, that is Big Brother watching us. And this is why we have to ensure that human rights is safeguarded through policies that are put in place. So there is a need to democratize COVID-19 digital health innovation policy, especially when the facts are uncertain and the stakes are high and decisions are urgent, as they often are in the course of a pandemic, as we have all seen. We shouldn't forget that emerging technology need well thought through processes. As scientists would normally talk of randomized controlled trials. Yes, that's going on the side, but we are in a situation where we've been given new technology. Some of them may not have been adequately gone through trials to see whether there are faults within them. But these are areas we have to look into going into the future. So the future, the momentum has to be kept going. There is no going back on digital revolution that this pandemic has brought upon us. And we must take up the advantage of the impetus it has provided. We cannot go back. We need a large-scale adoption and enhancement of the use of digital technology in healthcare. Like I said, these things have been around for a long time. But we as clinicians, we have been slow, even as governments, as policy makers, as decision makers, we've been slow to embrace them. It is essential to keep track of digital solutions currently being proposed to implement best practices and models of care in future. The NHS and the patient it serves will be better for it. COVID has overcome the resistance to the transition to digital health. The success will depend on digital health literacy, not just by patients, but by providers on the shop floor, at board level, across all sectors. Digital health literacy is key. The capacity to understand and to engage in health prevention activities, self-management as patients is very important, and collaboration. One cannot overemphasize the benefit of collaboration. It's one of the reasons why we were able to find vaccines within 12 months. So collaboration in the prevention, control, and alleviation of potential problems with digital technology is important. This will involve implementing a systematic health and life sciences approach that takes into account broad digital technology perspectives on human health. We cannot discountenance the effect the animals that live around us has on our health, and then the management of the surrounding environment as well. Adequate funding for health technology in the post-COVID era is important. It's paramount. It's what is essential. It's needed for research and development, and it's needed for deploying these tools in the health sector. So to just put a final say on this, we did not expect COVID, but it came. And what it has shown us is that the resistance to digital health was not founded because we've seen the benefits it has brought to us. Would we be going back to the old normal? Very unlikely. Most likely what we're going to see is a hybrid of the way we do things in the new world. Yes, the vaccine is with us. The rollout is going well, but we shouldn't forget the non-pharmaceutical interventions. They are still very important in our day-to-day lives. The social distancing, using of hand sanitizers, washing your hands, wearing masks, and staying safe are very, very important. Yes, the technology is there, but also the non-pharmaceutical interventions are very important, and I recommend them to you. Thank you for listening.
Amazing, fantastic presentation there. Thank you, Professor Rotimi. It's great to see you. We're here to answer any of your questions that you might have watching. So you can still submit them via the Q&A button, but we've had a few pre-submitted questions for you. So I'm going to start with this one, which you were just talking about at the end of your presentation there, but maybe we can go into a bit more detail. So how can we reflect on the COVID-19 pandemic to inform the health and care system of the future?
Yeah, thank you, Stephanie. Prior to COVID, we did have technology. We had technology in healthcare, but we were very cautious in adopting these new innovations. And that's because in healthcare, we tend to subject most of the things we use to rigorous clinical trials. Yeah. And for example, when you talk about biosensors, remote monitoring, these things existed before COVID, but were not in widespread use. But when COVID came on, we didn't have a choice because it's transmitted from person to person, and we had to ensure that people kept social distancing, even within the hospital, wearing your PPEs, to make sure that you don't come in direct contact with patients. And that's how, with the use of these apps and equipment, they've come into practice. And we have seen that they are effective. And so the future looks bright for technology in delivering healthcare. In my presentation, I spoke about artificial intelligence in interpreting CT images or X-ray images. They've been shown to be very effective, very accurate, and again, the speed at which you can receive results is tremendous. So it's going to become part of the tools we use in healthcare, no doubt about it.
Absolutely, and actually, the next question is about AI. So the question is, can we use artificial intelligence and big data better to track COVID-19 cases and develop vaccines? What are your thoughts on that?
Most definitely. When we look at the number of cases of COVID in the United Kingdom, for example, you're talking about 4.5 million cases with over 120,000 people dead. And we've vaccinated about 70 million people. Now, if we were to do that digitally or in longhand, you can imagine how long it's going to take for us to be able to analyze these data. So what artificial intelligence and big data has done was to give us that platform where we can analyze things easily, where we can look at hotspots area and know where to send supplies of vaccines through, or where to even place restrictions by monitoring using artificial intelligence, using geographical information systems, this has been very helpful in tracking the disease. When you go into a hotel or to a restaurant, with the apps that we use now, it knows where you've been, and this has helped us a lot in tracking the disease, as well as in the distribution of the vaccine. So artificial intelligence, big data is important. We aren't going to go back to the era where things are done manually. But going forward, I think, yes, we will get better. There are hitches here and there. There are the issues of cyber security. But again, big data using blockchain technology will help us tackle that.
Absolutely. Yeah, thank you. Okay, so next question is, how do you quality assure all of the technology that's been put out onto the market at present? Big question.
That's an interesting question. Because of the emergency or urgent nature of the pandemic, it was difficult, or it is difficult, to have subjected every piece of equipment to rigorous trials. But people on the shop floor will know when things are not working properly. And we have the MHRA, the regulators in the United Kingdom. When things go wrong, for example, you report it to them and this will be addressed. But I think going forward, when we have a repository of all the different apps, the different gadgets, I'm sure people will be looking into their safety, how long they can be used for, and other things like that. So that will come in future when the urgency, and which we are into at the moment, comes into effect. The quality assurance, there's no equipment that hasn't got potential problems. And when you identify such problems, you incident report it, and this is part of risk minimization or risk management. So if there are issues, my advice to end users will be, please report it to the manufacturers, and they will have a look at it. Just like the aviation industry does after a plane crash, they get the black box, analyze it, and then through such mechanisms, we do get improvement. So it's a continuous process.
Absolutely. Great, thank you. A couple more questions left then. So what are the UK regulations of telehealth?
Oh, UK regulations of telehealth. It's developing, that's what I would say. It's in its infancy, and that's because so far it hasn't been an established practice. But now we will have to look at various aspects of it: data protection, privacy, security. So there's a gamut of areas that we will have to look in terms of regulation. Not every manufacturer that says, oh yes, I've got this new product, it has to go through the testing and assurance processes. So I can see that coming in future. If we fail to do that and there are incidents, then the public will not trust us. We need the trust of the public to be certain that the equipment we use for remote consultation or remote monitoring are efficient and accurate. So that we will get from regulation, and I'm sure we will get there. It's a continuous process.
Absolutely, thank you. Sorry about my sneeze interruption there. I get really bad hay fever. Okay, we've got just under a minute left then. So final question, which you've obviously mentioned in question answers and the end of your presentation, but just one more time. How can we reflect on the COVID-19 pandemic to inform the health and care system of the future?
First and foremost is just to express my sympathy as well as empathy to those who have lost loved ones and those who are suffering from long COVID. Unfortunately, it came upon us. But with it, it's disrupted our lives. It's brought on new technology. It's brought on new ways of doing things, hybrid ways of doing things. And I think most definitely it's going to inform the way we practice medicine or the way we work. So this is the new world. Thank you.
Absolutely. Thank you so much. It's been really great to have you on, Professor Rotimi. We will see you next time.
Thank you. Thanks for having me.
Thanks. Bye. Fantastic. Okay, so for our final session, can't believe we're at the end already. Let's welcome Liz Ashall-Payne, co-founder and CEO at Orcher. Orcher assess digital health, helping health and care organisations to find, prescribe, embed and commission the best solutions. So Liz is here today to talk to us about collaboration and trends in health tech. Can't wait to hear what you've got to say, Liz, so handing over to you now.
Thank you so much, and I'm absolutely delighted to be here today to talk with you about the important trends in health tech and how things have changed, particularly since the start of COVID. As was mentioned, my name's Liz and I'm the founding chief exec at Orcher. Just a little bit about my background before I get into this. My background isn't actually techie or digital in any kind of sense. My background is clinical. I started my career working in the NHS as a clinician, working in complex paediatric care, and ultimately got really frustrated with the fact that I could only see one patient at a time. Fast forward almost 20 years from when I started working clinically, what I saw was the rise of digital health and health technologies. And I got really excited because what digital health and health technologies would enable us all to do is to be able to deploy healthcare solutions to millions of people all at the same time, which is obviously impossible as a clinician seeing one patient at a time. And that's what got me really interested in healthcare technologies. So I'm just going to start by sharing with you what the landscape of health technologies look like currently. So we currently have access to over 365,000 digital health products. A lot of these are in the form of an app on the Apple App Store or Google Play, but there are more and more native apps or web-based solutions coming to market. In fact, every day since the start of COVID, somewhere between 30 to 40 new products enter this marketplace every day. So it's a fast-growing environment. What we also know is that people are more likely to use digital technologies. So every day now, over 5 million people will download one of these digital health products. And that's grown by 25% since the start of COVID. So we've seen massive adoption in the world of digital health. And basically, if you can think of a health need or a condition, what I can tell you is that there is a digital health solution out there for you or somebody you're trying to care for. But the question isn't, is there a digital health technology that can help you? The question is there a good technology out there? Because unfortunately, in this space, most of these digital health technologies are not high quality and shouldn't really be trusted. I'll come on to that in a little bit and go into a little bit more detail. But the best analogy to think about this world in is if you had this situation in the world of drugs, you just would feel very, very worried about people going to find and buy drugs in an open marketplace. And that's where we are currently when it comes to digital health, with 5 million people downloading a solution every day. Now, what it does though mean is that there's a huge opportunity. We have access to hundreds of thousands of digital health solutions that our populations are using. We now have more smartphones on the planet than we have toilets or toothbrushes, because many people have 2 smartphone devices. But it's not just us as end users that are interested in these technologies. We're also seeing a huge adoption curve amongst our healthcare providers and healthcare professionals. So over 40% of healthcare professionals believe that healthcare technologies could reduce the number of visits required to a doctor's office. Over 90% believe that these healthcare technologies could improve their patients' health. and over 80% of healthcare professionals are already using smartphones and medical apps. So it's not just our end users that are seeing the opportunity, our healthcare providers and healthcare professionals are also seeing the opportunity. We also have a huge amount of policy drive towards supporting this movement towards using digital health. So the World Health Organization and NICE, the National Institute for Clinical Excellence, are really pushing forward that we should be using healthcare technologies with our patients and citizens to support health outcomes. So what I've described there is a huge opportunity and a huge landscape that we could be accessing. So that brings us to the question as to, well, why haven't we adopted digital health technologies into everyday work, life and practice? And I just wanted to talk through the 4 key barriers to the adoption, and then I'm going to talk to you about how we break down those barriers to adoption. So the first barrier to adoption is awareness is low. Some of you listening today may not have realised quite how many digital health technologies there are out there, and that awareness is low amongst our citizens, amongst our healthcare professionals and amongst our system leaders. As healthcare professionals, we're not trained in these technologies, and as such our awareness is low. Now, once you become aware that there are hundreds of thousands of digital health technologies and there's basically a digital health technology for every single need you could possibly imagine, the next big challenge is access. So where do you go to find these tools? And you might think, well, I'll go to the Apple App Store or Google Play and give it a go. Type in a word like dementia and see how many results you get. Some days on the Apple App Store you get no results found, when in fact there are over 6,000 products for dementia alone. So access at its most fundamental level is a real challenge. The next challenge with access is, how do I not only find a long list, but how do I find the right solution for me and my personal preferences and needs? And so if I wanted to find, say, for example, an anxiety solution, but there's another person who stood next to me who also wants an anxiety solution, but they're 13, it's highly likely that we're going to want different solutions. And if we layer on different personal preferences and needs, like hearing impairments, visual impairments, the fee associated with these technologies, what you realise very quickly is having access to lots and lots of solutions is not actually that helpful. What we need is access that allows us to find the best solution for our personal needs. So that's a real barrier to adoption. The next barrier, once you find a solution, is trust. And trust is not unfounded. Our research at Orca has found that only 20% of the landscape of digital health technologies out there can be trusted. And so that trust is not unfounded. We shouldn't be using these technologies. And what we're seeing at the moment is that 5 million people are downloading digital health solutions, but most of them are not safe, not regulated. And so the first thing we need to really ask ourselves is, how do we close that opportunity gap? If we can help people to find the best solution for them and their personal needs, and we know it's safe, we're going to have been able to have a positive impact. Now, the next challenge is around ongoing risk management and governance. And what I mean by this is, if you're a healthcare professional or a healthcare system and you're recommending solutions to your patients or public, and you can trust it today, what happens after you've recommended that solution and it changes? And the reality is, it will change. Digital health technologies are great because they listen to user feedback and they change and adapt according to that feedback. But that introduces a new risk. And that new risk means that we as healthcare professionals and healthcare systems will be nervous about recommending tools, because how do you manage any future risk and govern that risk? So these are the big four barriers to adoption, and these are also the big 4 barriers that Orca have been working to break down for the last 6 years. And I'm going to talk you through how we do that, so that you can hopefully start to do that yourself. So as I said before, only 20% of digital health solutions out there meet the quality criteria that you'd expect. And so trust is the biggest barrier to adoption. Therefore, the first thing we need to deal with is that trust barrier. So how do we do that? Well, if we start to look at the world of regulation and standards in the space of digital health technologies, we can see that there's a real puzzle. And the reason there's a puzzle is because there are lots and lots of standards, regulations and best practice guides, which fall into different domain areas, predominantly these 4 key domain areas. The first domain area is around data privacy. So you will have all heard of GDPR, but there are other areas of regulation, new emerging regulation around consent and authentication, interoperability. The second area is around data security, and this is focused on compliance with OWASP best guidance, and there are some other accreditation regimes such as Cyber Essentials and certain ISO regimes that need to be considered. The third area is around clinical and professional assurance, and this is really awash with standards and regulations. So we see standards relating to clinical safety, to clinical evidence. You may have heard of the medical device regulations. In this country, in the UK, with the NHS, we have something called the CQC, etc., etc. So this is awash with standards and regulations. And the fourth area is user experience, and this is currently a very lightweight area from a regulatory and standard perspective, predominantly around usability and accessibility. But again, this is something that's going to change over time. New regulations will emerge. And this is why it's a bit of a challenging landscape, because it's not a static one. This regulatory puzzle keeps changing. The next challenge with this regulatory puzzle is, how do you know what applies to what? So not all digital health solutions are the same. On one end of the spectrum, we might have something which is extremely low risk, say for example a digital recipe book, which is basically a book turned into a digital solution. And at the other end of the spectrum, we can have digital health solutions which are built on clinical algorithms that push and pull data in and out of clinical environments. And therefore, the way in which these solutions need to be assessed or these regulations applied is very different. Now, the third challenge with this puzzle is the product keeps changing. So as the product introduces new functions and features, new regulations will now need to be applied. So what we've seen over recent years is that new digital health assessment frameworks have started to emerge. And digital health assessment frameworks are predominantly at national level, with specific jurisdictions building health assessment frameworks. And what they're trying to do is make sense of that regulatory puzzle and put together some key assessment questions which can be applied to a product, and once applied and gone through and passed, can then build trust. So here in the UK with NHSX, we have something called the DTAC assessment framework, but there are about 28 just across Europe, and then there are many more across the world. So these digital health assessment frameworks are starting to emerge. Now, what you can imagine is that across all of these digital health assessment frameworks, there is a certain level of duplicated effort. So probably across all of them, around about 60 to 70% is actually the same. And so what we did at Orca was we pulled together the duplicated effort and built the Orca baseline review process. It's baseline because it's the coordinated effort on a global scale of an assessment process that everybody wants to know the answers to. And I'll explain how we build on from this baseline review process in a moment. So this is still a very robust process. It's around about 350 point evaluation, covering all those domains I mentioned earlier on. In order to run this at scale and pace, we've built some technology called an accreditation engine, which basically allows us to process digital technology in a proportionate, repeatable way. And it's that repeatability which is really important. So the engine will trigger a re-review every time the product updates and changes. Now, this is still a manual process. Of course, people still need to assess the technologies and hand off to subject matter experts as required, but the technology enables this process to be very efficient and highly effective. So it takes somewhere between 2 to 3 hours for us to process a product through this review process. And what we do through the engine is we also generate improvement reports that go back to the innovator to advise them on how to meet any gaps in this process. Now, what we then do is we then build on this baseline review. So this is the horizontal area at the bottom, the ORCA baseline assessment, and then we build verticals depending on the country that we're working in. So the first vertical is the Netherlands, the Dutch accreditation assessment, and you can see that they have an additional criteria around user experience, which is layered on top of the ORCA baseline assessment. You can see across the 5 nations in the Nordics, there are 4 additional elements, and you can see on vertical 4 the additional requirements for the NHS DTAC. Now, what this means and why this is really important is, first of all, nobody has to start from the beginning now. We've already reviewed 13,000 digital health technologies at that baseline assessment. So when we move and work in a new jurisdiction, we're able to use the information that we already have and just build on top additional criteria. What it also means is, as an innovator, you only have to go through the bulk of the assessment once. And that's really powerful because it can take time to get through these processes. And it also allows for simplicity and clarity on what you need to do as an innovator to access these new markets. Now, obviously, I've explained how you build trust, how you apply regulations, what those assessment frameworks look like. And that's great because you now know what solutions can be trusted. But that's only the first step in breaking down those barriers. The next step is we now need to tell people which ones can be trusted, because as I mentioned before, over 5 million people every day will download a digital health solution. So how do we do that? Well, what we've been doing is working with different parts of the ecosystem in health and care to create digital health libraries, which are home branded and targeted to specific populations. So, for example, one on there that you can see is the Northern Ireland Digital Health Library for Dementia. And this is created for people living with dementia and their carers, and it's filled with high quality digital health technologies that can support somebody living with dementia and the people caring for them. And this is promoted and campaigned to that population so that people now become aware and have somewhere they can access solutions that can be trusted. And these digital health libraries are not only providing a long list, they also have the filter option. And filter is something that we're all very used to when we go to any website. So say, for example, if all of us wanted to buy a pair of black trousers and we all went to the same store, it's highly likely that we would probably, most of us, buy different pairs of black trousers. Because we would, and if we went to a website to try and search that black trouser, what we would do is filter out the thousands of black trousers in that store according to size, cost, shape, gender, etc. So filter is something that's very, very common to us. And that's what these digital health libraries do. You can type in a word like anxiety, and there are lots and lots and lots of digital health solutions for anxiety, but then you can filter according to your personal preferences and need. So age plays a role, so does technological preferences, cost, functions and features. And what that filtration means is that you get to the best solution for you far faster. I'm going to share some data that we have across these digital health libraries in a moment. But before I do, I just wanted to explain how these digital health libraries then support health and care professionals to be able to activate people to use digital health solutions. So what we know is that the people who are using digital health technologies at the moment and the people who would want to come to one of these libraries, those communities are probably our already activated healthy communities. And what we really want to do is start to activate the unactivated communities across our populations. And so how do we do that? Well, what we need to do is find the trusted people who have touch points with those unactivated communities. And people have touch points with their healthcare professionals at point of a health need. So what we do through these digital health libraries is we have a new lens now for the healthcare professional, who first of all enters through a training program so that they can build up their knowledge and awareness of what's out there. And then they're able to use this library now, not as a library, but as a formulary. And a formulary is something that healthcare professionals are very used to using to prescribe drugs from. So this digital health formulary is now exactly that. The healthcare professional is able to search for, filter, find the best product for their patient or the citizen they're trying to support, and then recommend it via text message through this system. Now, the reason that's important is because of that final barrier I mentioned, governance. The system is able to monitor what solutions are going where and whether that person downloaded. Because the engine is continuously re-reviewing the product every time it updates and changes, and that audit trail has been established, we can do a recall should that be required, and therefore future risk is managed. So it's been fascinating to be able to work not only in this country, but in 9 other countries to try and support the adoption of these digital health solutions. And what we've seen since the start of COVID is some fascinating data about what people are searching for. So this is end users, patients and healthcare professionals. What are they searching for since the start of COVID? So around about March last year, when COVID first hit in this country, we saw a massive rise in people searching for solutions around COVID-19, wanting to learn more about this virus. And we also saw a significant increase in people searching for tools to help them with their respiratory conditions, so asthma and COPD, because we knew that that virus was one that would impact on chest, and therefore if you lived with a respiratory condition, you needed to be able to self-manage because you don't want to be contracting the virus. So we saw a huge increase in those areas. Now, as we moved through into the pandemic and into lockdown, we saw a significant rise in the searches around mental health conditions. Now, mental health has always been a very hot search for and downloaded area in the world of digital health, but it became even more important as we weren't able to go and access some of these face-to-face services. So mental health took a massive rise in adoption through the middle part of the year. And then in the final part of last year, we saw a significant increase around diet and fitness. And this correlated with all the research that came out around how obese people are experiencing more challenges if they contract the virus, and how people living with diabetes could also have a more negative consequence if they contracted the virus. And so diet and fitness became a huge hot topic and area of focus. Now, what's also been interesting is just tracking what digital health solutions are being searched for to support our new long-term condition, long COVID. And this heat map really starts to show how, as the year went on and as more people started to experience long COVID, the heat map gets darker. And what that's telling us is that more people were searching for solutions to help with long COVID symptoms and this new long-term condition. What you can also note, though, is that the the opportunity for new innovations was just a little bit behind the need. So we knew about long COVID, and people were searching for products to deal with the symptoms of long COVID. But as we then started to see that this was going to be a new long-term condition, you can see that the graph on the bottom shows a sharp uptake of new products coming to market to support this new long-term condition that we're living with. And I think that we're going to see over the next 12 months more specific innovations to support long COVID very directly. And now's the time really for digital. I think what the pandemic has shown us all is that digital is the way in which we've been able to get through this pandemic, both through technologies like the one that I'm on right now, and through healthcare technologies. And these are just some of the stats that we've seen around increases in people viewing, searching and downloading digital health solutions. But the biggest one by a mile is the number of recommendation increase. So that third stat, 6,500% more healthcare professionals are now recommending digital health technologies to their patients. And so just thinking through the three key things that we must do if we're really going to be able to support our digital citizens and patients, we have to think about how we're going to build trust in digital health. We have to think about how we're going to activate the unactivated communities. And we also have to think about ongoing governance and risk management. And it's those three key things coming together that will really help us enable more people to use high quality digital health tools. But there is still quite a lot more to do. So two key areas that we really need to think about moving forward is around procurement and reimbursement. So who pays for these tools? So at the minute, certain parts of our healthcare system are paying and commissioning for digital health technologies on behalf of their communities and patients, but that isn't standardised across the country. So we have to think carefully about who pays for these solutions, because what we don't want to do is create a further divide between people who can afford these solutions and those who can't. And then the other area that we need to think about is education. So we need to start embedding digital health tools into education as soon as possible. I reflect all the time that when I did my training as a clinician, it's nearly 25 years ago, if I redid that training tomorrow, it hasn't changed that much. And digital health is not a part of that curriculum. So we need to really embed this into education. But that education doesn't stop there. We need to start to be able to educate our citizens and our populations to be able to use and embrace these technologies so that we can get the benefit from them. So thank you so much for listening. I hope that's given you some insights into the world of digital health and some of the trends around it. If you want to ask me any questions, I'm very happy to take them. Thank you so much.
Amazing. Thank you so much, Liz. Brilliant presentation there. How are you feeling after that?
Yeah, very well, thank you.
Good, good. We've had a few questions come in for you. As ever, if any questions do pop into your heads at home watching as we're chatting, you can submit them via the Q&A button. But let's get started with these that we've got already, Liz. So the first question is, and we've definitely touched on this already, but maybe we could go into a bit more detail. And the question is, what are the evolving trends in digital health in response to COVID?
So I did touch on this obviously in my presentation. I think that, the biggest trend is the adoption. More people are now using digital health than ever before. Every day, 5 million people download a health app, and that's increased by 25% since the start of COVID, and that trend is accelerating all the time. It's also a huge trend that healthcare professionals are looking to embrace these technologies into clinical care and care pathways. And again, we're seeing rapid adoption of digital health to not only replace what was a face-to-face consultation with a digital intervention, but also to replace parts of the pathway, particularly with the significant waiting list that we now have, so diagnostics and interventions. Now, looking at what solutions and what the trends are around those solutions, the biggest area of growth by a significant way actually is around mental health. And it's always been a very hot topic for digital and digital health, but it's become even more so now, again, since we've seen a significant rise in need and we don't have the capacity to be able to deliver care to all those people who need it. So mental health is a big area of growth, particularly since the start of COVID.
Absolutely. And we actually, the first session this morning was by a woman called Saria from Good Things Foundation, which you may have heard of, but they were talking very much about, education and trying to lessen the gap in digital equality. So it might be quite interesting for you to reach out to those. I think the stat was 77% of people who used an e-tool had found their mental health improved, which I just thought was absolutely incredible. So very interesting and, like you say, hot topic of conversation at the moment. Next question is there a need for long COVID apps to fill the gap in the market?
Absolutely. So it's been really interesting because long COVID is our new long-term condition. And since around about September last year, we started to see significant searching for solutions that could support with the symptoms of long COVID. Obviously, what we've then learned is that we need new innovations to support with long COVID directly rather than just dealing with the symptoms. So since the start of this year, we've seen a huge upward trend in the development of new innovations to support this new long-term condition. But obviously, there is a marketplace requirement for a number of these solutions. So if you're a child that's living with long COVID versus an adult living with long COVID, we're going to need different solutions. And there are lots of other different demographic profiles that we need to consider. So yeah, there's a bit of a plea actually to the world of innovators to start creating these solutions to help people live and deal with long COVID very, very specifically.
Absolutely. This was another session earlier in the week as well. It was so interesting. You could watch them back hopefully and reach out to them. Loads of chance for cross collaboration here as well, though, which is really exciting. So I'm sure there's going to be some really good solutions coming very soon. We'll talk about what we think the future is going to look like shortly. But next question is, how can we support the digital patient post-pandemic?
So I think we've touched on a couple of these areas, but if we think about a post-pandemic world and where we think we're going to get to with this virus, we're expecting that we're going to have to live with this. And so having digital technologies to be able to support with health intervention, diagnostics and appointments is absolutely critical. So what are the things that we need to consider? Well, the big thing is around education, which was where I just finished the presentation. We have to embed digital tools and therapeutics into the curriculum for healthcare professionals who would be recommending these solutions. And obviously we have to absolutely be training and educating our citizens and patients who will be using these solutions. So I think education is a big next phase. The next thing that we also need to do is also think about who pays for these solutions. So in order to support digital patients in a post-pandemic world, we need to think carefully about who's going to pay for these interventions on behalf of patients, because as a healthcare professional, what we don't want to be doing is recommending solutions where the end user has to pay, which then could create a disincentive for that person to then use that technology. So I think education and thinking about who pays is absolutely critical. And I think that the reality is the genie is out of the box. Digital health is going nowhere. We need to really embrace these technologies. Patients, people are already using them. So the post-pandemic world is one where digital health is front and centre.
Absolutely, yeah. And the next question was, how do we support digital health and equality? What do you think we could be doing, either, ORCA or the local councils, or, what can we be doing to help support that?
So, I mean, there's a number of things, but if we look at who are currently using digital health solutions, these are our communities that are probably already quite activated to stay healthy and well. And so the people we really need to activate are the people who aren't using digital technologies. And what we found from our work is that the biggest activator in a healthcare system is the healthcare professional who have a touch point with that person or individual. And if your healthcare professional recommends that you do something, what we also know is you are 70% more likely to do it. So in order to activate the unactivated communities, we first of all have to activate our trusted healthcare professionals. The other part to that, though, is it's not just about the healthcare professional communities and healthcare doing this alone. I think we need to look out to our communities and embrace community assets in a new way. So who else have touch points with deprived communities and unactivated communities? So that may be religious organisations, it's schools, it's mobile phone shops. They're having touch point citizens. Why not embrace these these environments and really utilise the community assets that we have in a much more lateral way? This isn't just a health challenge. It's far broader.
Absolutely, such a good idea. Get them in the phone shops. Get them at the source.
Absolutely.
Amazing. We've just had another question come in, and it is there legislation in place to enable these digital apps to share outputs in a common standard that clinicians can then access? So there is a bit further for an example. So it says lots of diabetes apps to assist people, but can the outputs be utilised by clinicians in a common format?
So really, really great question. So the rules for interoperability in the way that's being described there are basically in development. So we are going to start to see new regulation and legislation around this space. I think when we talk about interoperability, the rules of engagement are really important to get that quality assurance of the data that's coming out of these products and into new environments in a safe, consistent manner. But the second thing that we also need to think through is where does that data go? And how is it seen and who sees it? So along with interoperability, we also have to think about consent. Again, lots of work being done around consent so that I, as a patient or a person, can consent to share different pieces of information with different parts of my community. So it might be family, health, care, education. But the other bit is also verification and authentication, so that if I'm sharing data, you will also want to verify, is that data actually from Liz, and is it Liz's data? So there's a number of other regulations and standards that are emerging around those other areas. And then the other area, just to note on interoperability, is it's not just a technical challenge. Of course, there's the rules and then the technical integration, but there's also the shift that we need to think through and the reality check of the tsunami of data that would potentially be coming into our environments as clinicians. How do we deal with that? What does that mean for our duty of care to our patients? How do we view that data? What do we do if we see a risk? And so there's a whole load of other areas around interoperability that we need to address.
Definitely, it's quite the minefield, but I'm sure there'll be someone out there who's got the solution. All right, thank you so much. We've got time just for one more question, and I'd like you to fast forward, say 5 years' time. What do you think the future looks like for this?
So I think there's two things, and it's very related to that last question. But the first is I believe that digital health will be prescribed as frequently as drugs are. And potentially alongside rather than just being always instead of. And then the second thing is around that interoperability. I'd like to see in 5 years the ability to have dashboards of data that help you to not only find patients who require more intervention, but to also be able to risk stratify a population level and therefore find and commission the relevant services at the right time.
Brilliant. Thank you so much. Such interesting stuff and a great way to end this week's event. So thank you so much, Liz. Any final words?
No, if people want to get in touch, if there's anything I can do, please do reach out. I think my contact details are on the last slide, so you're very welcome to reach out, and thank you very much for inviting me.
Of course, our pleasure. Thank you so much, Liz. We'll see you next time.
Thank you.
Amazing. Well, that is it for today and indeed for this week's conference. And I just want to take this opportunity to say a huge thank you to all of our presenters today. Haven't they been fantastic? And all week. All of our sponsors, exhibitors, the team behind the scenes who make this all possible. And of course, for you for watching and taking part. So just to let you know, the CPD certificates will be circulated to all attendees post-event, so do look out for those. And we hope you'll join us at the Autumn UK event, which is taking place from the 5th to the 7th of October this year. But the next event in the series takes place in just under 2 weeks' time, which will be Arab Health Week from the 22nd to the 24th of June, sorry. So we hope to see you there, but for now, have a great rest of your day and we will see you next time. Thank you.